vulvar cancer. So the outline is I am going to review what to cover depending on stage, right? Review contouring guidelines. I'm not going to do the live demonstration, so that's not there. And I'm going to tell you how to take care of the patients, because I think this is actually more relevant than anything else, because a break in treatment is bad for the patients. I'm just going to give you some guidelines on how to take care of these patients, because what I tell them, the first thing I tell patients who have vulvar cancer, this is the hardest cancer that I treat, and it's the hardest for you. And seriously, you know what my answer to them is? I go, you're going to hate me by the 4th or 5th week of your treatment, but I promise you all these side effects will go away 2 weeks after we get done. And truly, they get to me in the 4th week, they're like, yeah, I hate you. And they're ready to quit. And it's got to be more support. You've got to hold their hands. And I'm going to give you some other advices. So as we all know, vulvar cancer is very rare. It is 4 to 5% of all gynecological cancers. I do think you see more in the patients who are HIV positive. So I do know it's more common actually in Africa. I don't know the incidence is in Indonesia. I think the most important thing to know is that there are 2 different types of vulvar cancer, right? So in the US and Europe, we see a lot of the non-HPV related vulvar cancers, and these are associated with lichen sclerosis, and it's about 60% of the vulvar cancers. These are actually, I'm going to be honest, the hardest to treat, and I do believe they're really more radio resistant than we know. The second type is the HPV related tumors, which is about 40% of all vulvar cancers. And these are the ones that have come in the younger patients, the HIV positive patients, and these are actually very radiosensitive. The HPV related tumors act more like the anal cancers, where the non-HPV related tumors actually are, like I said, more radio resistant, probably need higher doses and probably something more than what we are doing now. So where does the most common sites, right? And this is also important for you to know, right? So the labia, of course, is the most common site. 2/3 of the cases all occur there. The other sites are perineal body, mons, clitoris, and all of that, and the Bartlett's gland. Okay, so the Bartlett's gland is the only one that's not going to be squamous cell carcinoma, okay? Everything else is squamous cell carcinoma. Bartlett's gland, you can get either squamous cell carcinoma or adeno. So if you see an adeno, most likely it's arising from the Bartlett's gland. Again, please, I can't see the chat, so Becky, you're going to have to stop me and ask questions. If you have questions, please ask. So how does it spread? And this is really important. 1, direct extension, vagina, urethra, anus, and pelvic bones. Okay, but the most common spread is to the nodes. And the most common area is to the first one area, right, is the superficial deep inguinals. And it really is correlated with the depth of invasion and the size of the tumor. Okay, so as you can see, if you have less than 1 millimeter, the risk of having inguinal nodes is less than 5%. But as you go up to more than 5 millimeters invasion, you have a 40% risk of having inguinal node metastases. And the same with size. If you have tumor size that's greater than 2 cms, you have a greater than 20% inguinal node metastases. Once the inguinal nodes, so this actually also works just like cervix cancer. It really goes logically up, right? So it first goes to inguinal nodes, and then it goes to pelvic nodes, then it goes to common iliac nodes, and then it goes to periortics. You're not going to have a pelvic node if you don't have an inguinal node. Now, obturator nodes kind of fall in between. So you may have a positive obturator node and not have an inguinal. It's almost rare. It's usually you're always going to have an inguinal node, then it's a pelvic node. But it's important to know that, because if you get a positive pelvic node, you really need to make sure you can find that positive inguinal node. So as I said, first echelon, superficial inguinal femoral, second echelon, deep femoral, deep inguinal femoral and femoral, and the third is external iliac and pelvic nodes. This is the one tumor that does not involve the sacral nodes. Okay, that's also important to know. So when you're designing your fields, know that the sacral nodes, unless there's rectal involvement, the sacral nodes are not going to be at risk. even if there's really anal involvement, the sacral nodes are not going to be at risk. So this is the one tumor that really doesn't go to the sacral nodes, and which is great because then you can spare, right, the bones and that midline structure, because you don't really need to cover the sacral nodes unless there's an organ that is involved, like the rectum. So can we do the first, I'm going to stop sharing for a minute, the first Zoom poll. All right. Oh, that's not it. Do we not have the first Zoom poll? That wasn't the first question.
I only have, my first question is this one.
Well, then I can, that's okay. Then I'll just ask it myself on the thing, okay? A patient with vulvar cancer who's felt to be unresectable due to involvement of the right labial majora and no vaginal involvement and no negative, should the sacral nodes be covered? So the question is yes or no. So why don't we, that's okay, no worries. Raise hand so we can look. Should the sacral nodes, I just said it right, so this is gonna be easy, but let's just raise our hand. Do the sacral nodes need to be covered? Yes, for yes. Okay, how about no? See a raise of hands? Can you guys, there you go, perfect, right. And I think you guys, this is important because it really does make a difference in your, perfect, great, I see that. Thank you, everybody. That was an easy one, but I just want to make sure that we get that, because you see, that is one of the biggest mistakes that I see from people's contours, right? Okay, so let's talk about workup. And I think this is also important because this really is going to help you contour. Okay, so this is why I'm doing all of this. So workup, it should include an H&P, a pap smear, right? An EUA. And so that's important. I don't do EUAs on all my vulvar cancer patients, but I do it for my vaginal cancer patients. But I do believe if you're going to treat these patients definitively, it probably is a good idea to do an EUA so that you really know the full extent of the disease, right? So you need to know if there's vagina involvement. You need to know if there's anal involvement. You need to know. So it's really, I think an EUA is actually a great way to do this. We try to do a good job in the office as well, but sometimes an EUA is actually easy, right? We unfortunately always do an MRI. Again, it does help us with the vaginal involvement. It also tells us, you know, if there's groins and pelvic nodes, and it shows us the full extent of disease. It's also, we do fuse it with our simulation, so it helps us contour, right? If you can do an MRI, that would be amazing. A CT plus or minus PET, again, very important for both nodal and distal involvement, chest x-ray, lymph node biopsy. So the other thing, just which is not on here, is a great way to look at inguinal node involvement is ultrasound, right? And it's a great way to follow patients that you decide. So this is actually just a thought, right? There are patients that I treat just for positive nodes, and I just treat the vulva. So how do I follow the groins? Actually, they will get ultrasounds every 3 months for 2 years to make sure the groins haven't failed. Okay, even though, so the reason I'm not treating the groins is because they were addressed surgically, so, right? So the only reason why I'm treating the vulva is because she had positive margins, right? So the key is you just have to know. So then to follow them, ultrasounds are great. Ultrasounds are a great way to follow inguinal nodes. That's an important point too. Okay, so staging, this is the staging. I'm not going to go through a lot of this, but I think the key is positive pelvic nodes fall into a stage 4. So you do need to know that, but that does not mean they're not curable. Okay, patients with positive pelvic nodes, you can cure with definitive chemo RT. Know that. Now, positive periortics, hard. Positive pelvic nodes, curable, even though they're stage 4. Okay. Again, an important point to know. Treatment, it should be a multidisciplinary evaluation, right? So the options are wide local excision plus or minus radiation therapy, vulvectomy, sentinel nodes, and definitive chemo RT. And it really should be a discussion with your surgeon and you on what is the best way to treat the patient. People are quiet. So this is how we do it at MD Anderson. So we do a multi-D and we ask, is the patient, is it resectable? Okay, if it's not resectable, which means it's involving, it's close to the anus, it's close to the urethra, it's involving the vagina, then definitive chemo RT. Okay, but let's say it's resectable, gross nodes. So how do you find out if there's gross nodes? You can do sentinel nodes, which is what we do in the United States, but you can do a node dissection too. And then depending on risk factors, they may need radiation or not, right? HPV associated. Again, that's, the reason why you want to know HPV is that you could maybe lower the dose, right? And then you decide on definitive radiation therapy or not. Sorry. Okay. So how do we treat these patients? And I don't know, you guys are all young, and I don't know how you guys are doing in Indonesia, but when I first started training, how do we treat them? We treat them with this big AP field and this narrow PA field, right? So that would cover all the disease. But IMRT really, this is the one cancer where IMRT, well, that's not true. There's 100 cancers that IMRT actually is very useful, but for vulvar, it definitely is useful, right? It helps protect the skin between the PTVs. It protects the central bone, pelvic bowel. It helps protect the femoral heads, and you can get concurrent boost. So there's huge advantages. I mean, it really has reduced toxicity compared to those big fields that we used to do before. The problem with IMRT is you've got to know what to treat. Okay, and this is important. And there's still really a big controversy on what the targets should be, right? How do you contour the groins? Does the skin bridge need to be contoured? Do you cover the mons? And I'm going to tell you no. And I'm going to show you no, right? Vaginal coverage. How much of the vagina? We're going to talk a little bit about that. And I'm going to talk a little bit about that, okay? Do you need to include the whole vulva? We don't know that at this moment in time. Most people are still treating the whole vulva, but do we really know? Maybe in the HPV positive patients, we may not need to treat the whole vulva, but we don't know that. So there is, a lot of controversy, but IMRT has a lot of advantages, and it really is the best way to treat these patients. So dosing, very important. Microscopic dose, 45 to 50 gray. Okay, so if there's no ECC, even if the patient has positive nodes and there's nothing that you see on your CT scan, 45 to 50 gray is enough. Gross disease, we really take to 66. So we treat these more like a head and neck cancer, right? So if you have positive ECE, you want to go above 60, right? If you have positive margins, at least 60. If you're going definitive, I know this sounds bad, but we take the vulva dose to 66 and they do well, right? So you shouldn't really go more than 2 gray. You can probably, to the nodes, you could go probably a little bit higher. So I actually disagree with this slide. This slide is what we do at Anderson, but I think the nodes in the groin, you could probably take at 2.2 or 2.1 or 2.2. You could. We tend to do 2 gray, wait for the response and come back and boost the node. So it's just really up to you. But the nodes you can, but the vulva, the gross disease in the vulva, you should not take higher than 2 gray per fraction. Okay. So how do you simulate? So this is a patient. So at our institution, we do frog leg. So I'm just going to tell you another thing is, I think for vulva, there's actually a band that you can, there's a bar, there's actually a setup where you can get a bar that separates the legs out and will keep their legs straight, but separates them out, that I think would be more reliable. I think the problem with frog leg is it's hard to set up. I do think straight leg is a better way to set up. So this patient actually has bolus. We actually don't simulate anymore with bolus. We treat with bolus. We don't simulate with bolus anymore because it's hard to contour and it's hard to plan. So we do, but we will treat with bolus. We do definitely, like I say, do frog leg, and we do put markers. And I think that's important. If you have a gross lesion, if you can put little, those sticky wires around that disease, it will help you contour. Again, you guys are very quiet, so please ask questions.
Actually, there's a question that is in the chat, if that's okay.
Yes.
It's from Dr. Kojogi, but there, he mentions, and I think this relates to the some topics you might be touching on, but there's often discussion about sparing the skin versus having adequate PTV margin anteriorly. How do you approach this at MD Anderson?
Yeah, so I'm going to talk about that in a minute, so I'll come back to that. So give me a minute and I'll come back to that. Okay, good question. I will come back to that. So we do, at Anderson, we do TLDs. So we will, and that's again a hard thing for, I think, everybody to do. We do have a lot of resources, right? So all of our vulvar cancers get TLDs. We do TLDs with bolus and without bolus. And I tell you why. If it's an anal lesion, right, the skin is going to cover the anus, so you probably don't need bolus. But if it's a Mons lesion or if it's a clitoral lesion, that's why you get the legs separated, right? You're going to need bolus. So we always do TLDs just to determine. We use between 3 millimeters and 5 millimeters bolus. My rule is I use bolus for the first 3 weeks, and we look at the skin reaction and decide if we continue or not. Some people do bolus every other week, like the breast. The TLDs really do help. I'm going to tell you, if it's a Mons lesion, I mean, if it's on the labia majora or on the clitoris, it's going to need bolus. So target location. So we do daily CBCT. We do use a generous PTV, 8 millimeters to 1 cm. So let's talk about skin sparing, right? This is where do we spare the skin? So that's a good question. So we do plan with a false structure like they do with anus, so that we actually make sure, so that, and that's a planning system issue, right? With Ray Station and Pinnacle, you had to add a false structure to make sure you got dose outside the skin, so you're treating all that lesion. Where I think at Eclipse, you don't have to use the false structure. But yes, for the PTV, I mean, this is where you want to treat the skin, but you don't want to treat unnecessary skin. So you don't want to treat the Mons if you don't need to treat the Mons. But if your PTV does go out and you need to treat the skin, you need to treat the skin, right? So it's a good question. Does that answer that question? And we can talk back in a minute, okay? Let me come back to that for all as well. So what is your superior border? If it's negative inguinal nodes and you're treating with definitive chemo-RT, the bottom of the SI joint, so you just really need to treat the low pelvic nodes. You really just need to treat the obturators and the low external and internal iliacs. You really don't have to go all the way up to treat all of the external iliacs. And that's with negative inguinals. If you have positive inguinals, that means you do need to treat all of the external and internal iliacs, but you don't need to treat the common iliacs, okay? You only treat the common iliacs if you have positive pelvic nodes. And that is important. So if you have negative inguinals, you do not need to treat a whole pelvic field. And if you have positive inguinals but negative pelvic, again, you really can go to like L5S1. You don't need to treat the entire common iliacs. Because as remember what I said, it really goes in an orderly fashion. And this is one cancer that truly goes in an orderly fashion. So now we have the first poll question, right? You have this one, correct? Okay. So the question is, the question in a patient, I can't read. Okay. A patient with vulvar cancer who's felt to be unresectable due to the involvement of the clitoris, but is no negative by PET CT and is getting definitive treatment. What should the top of the border of the field be?
And I'll give it another 10 seconds so we can have more responses roll in.
Yeah, they're doing a pretty good job.
All right, I'm going to wrap it up.
So yes. So 50% said bottom of the SI joints. That's correct. I mean, you're not going to be wrong with L5S1, but I mean, these advantage of having a lower field, right? Especially in older patients, you're not treating as much bowel. So if you have negative inguinals, you really don't need to go that high as L5S1. You can even go mid-SI, right? To make sure you're covering everything. All right. Thank you, everyone. So let's go to the next. Are we ready to go? You want to take that off? Okay. All right. So there are some guidelines, and I think this is probably the best just because this is probably one of the most popular of the guidelines, but Sushil has a paper that has gone through Dr. Barrawell has a paper, and I'm going to send you that reference, but probably this is the most cited consensus paper on IMRT contouring, okay? So this is actually just a figure from those contourings. And as you can see, right, so here's the lymph node that goes to the skin, so you're not going to be sparing skin right there. But you can see you've got to cover the obturator nodes, especially if you have positive inguinals. But even if you don't, the obturator nodes are going to be the next echelon up. So as you can see, the other thing that's really important, and I'm going to show you more, is you really just need to go to the muscles, right? And you just need to go behind the vessels. You really don't need to go past that area. So you can see right here. And as we go further down, you go to the muscle and you go to the muscle and then you just go around. You are going to spare the mons. You do not need to treat the mons unless there is disease that was involving the mons. The mons does not need to be treated. That's very important. So as we go further down, let's say to the clitoris, right? So again, you can see where the mons is being spared, right? So we're not going to cover that mons up there. And you can see where the nodes are actually contoured separately. So don't make one big structure. Because what's the issue with treating the mons? The issue with treating the mons is you're going to get swelling. This is what causes long-term toxicity. And there is no reason, unless there's multiple skin nodules, there is no reason to cover the mons. The mons is not going to be at risk. So as you can see, each structure is contoured separately. So here's the left groin, here's the right groin. And so this is the clitoris, right? And then we're going down to the vagina. So let's talk about the vagina. The vagina, if there's no vaginal involvement, you do still need to treat at least 1 to 2 cms of the distal vagina. That's important. If there is vaginal involvement, then you're going to include that vaginal involvement and then 2 to 3 cms superior to it. But it is important to remember that you still have to treat a little bit of the vagina. So you can see where that vagina is being included, right? Right here. See where that vagina is being included. So the recommendation is to treat at least 1 to 2 cms of the distal vagina. Now here, I probably would have done something a little bit different. So I disagree with these contours. So right, this, I think they're going too far back. I don't think you need, it's never going to go this far laterally. And again, I would have made these 2 different structures, right? Which we just talked about. Then again, as we go down, 2 structures, like we said, and then you're going to now cover the whole vulva. Okay, but as you can see higher up where the clitoris, you're not covering that mons. That's important.
Sorry, a question.
Yeah.
Can you speak a little bit about how far you extend anterolaterally in those inguinal pockets? And I think you touched on it a little bit. You wouldn't extend it deep laterally in between those muscles.
I'm actually going to show you a couple more slides on that. So give me a minute. Oh. Yeah, good question. I'm going to show you actually more close-up slides on that. Okay. So there's been a lot of papers that have been done that show you where these groins lie, the nodes lie, right? So the nodes really do sit medial or anterior medial to the femoral and the saphenous veins. So not 7 millimeters around the vessels, they really are medial or anterior medial. So to cover 90% of the disease, you have to have like about a 35 millimeter margin anterior medial, 23 anterior. And I'm going to go through all of this, but this is a great slide. And you guys are going to have this slide set so you can really look at it. But we're going to go further and look at it more carefully. So the key is you want to look at, so this again, I would cover, this didn't include the obturator nodes, so you would include the obturator nodes, right? But you want to follow the vessels out. So there's no vessels here, right? So you're going to stop your contour right there. Again, same thing, I would have covered the obturator nodes, which aren't covered here, right? So you want to cover the obturator nodes, but this is your inguinal nodes right here. You want to go to the muscle, and that's a positive groin node, right? So here, you want to just go right posterior to the vessels, and then you want to go up and you want to follow that muscle, and then you want to go around. Your nodes are going to be anterior and anterior medial to these vessels. And that's key. Does that explain that question? Please ask.
It does for me, yes.
Okay.
Thank you.
So again, just more examples of it, right? So as we go lower, right? So it's going to be medial to the saphenous along the pectus, right? So here's the saphenous vein, here's your muscle. So you're going to, you don't want to include the muscle because this is your CTV. So here's your vessels, right? So you're going to go up right behind the vessels, following that muscle, and then you're going to go around and go right around there. Okay. So that blue is what is going to be your CTV, not, round like that, but you want to go and cover your CTV. And then to be honest, because we do frog leg, do a 1 cm margin because of the unreliability of the position. But if you don't do frog leg, you have the patient's leg, I think 7 millimeters probably is enough for the CTV. Okay. So it's not a circle. You want to make sure you have margin around, but you don't need to go. So you don't need to go over here, right? You just literally have to be right posterior to those vessels because there's no nodes that are going to fall here. What's the problem by extending your CTV down here? Your PTV is going to be down here, and then you're going to hit the femoral heads. And that's where you're going to get fractures. So the less bone that you treat, the better off you are. Okay. And that's one of the biggest mistakes I see is that people actually will contour all. You just literally have to go right behind those vessels. And by the way, the other reference is Dr. Eifel's book, and I'm going to send you guys that reference because it's an amazing book, and all these pictures are from Dr. Eifel's books, and she really does a great job of showing you contours, and especially vulvar contours. I think that book is amazing. So I will send you that reference.
Another question that came in from Dr. Perdogi is, what about the gap between the lateral part of the pectineus posteriorly and then the rectus femoris anteriorly? Because it seems like the guidelines vary in that situation.
Yeah, that's a good question. I think you have to see where the nodes are and what your clinical thought is. We really try to follow these guidelines. That's a good question. And I think to be honest, I would have to see exactly what he's talking about to answer it. So maybe afterwards you can show me a picture. So contouring the vulva, this is probably the hardest part of it. And this truly is the hardest. This is where we really have a lot of things. So you want to do fiducials to define the tumor and the critical structures. Again, like I said, the EUA is important. And as I mentioned, you really should cover at least 1 to 2 cms of the vagina if it's not involved. You do not need to cover all the mons, right? The clitoris and the anus, right? Key, as I mentioned, you don't need to cover the mons. And this is what happens if you are covering the mons, right? This is the big side effect of patients with mons. But hey, I would love to see a picture so I can see what he's talking about. If we can, once I'm done and we can see that. So you must know what the borders of the tumor are. At post-op, you got to cover the scar in the post-op bed and margin. And you can use 2 different dose levels. So we do, right? So here, the vulva would get 45 gray. And the GTV would get 50, and then we'd come back and boost the GTV to 66. You want to avoid the thighs and you want to avoid the mons. As I said, it's really hard to treat these patients. And key is patients really do get pain up front, and really you need to control the pain. We do give them pain medicines. We do cis-spats up front. And actually, Dr. Eiffel really believes that if you can start with them with antibiotics, that's really important. But key is I do get them on yeast medicine pretty early within first 2 weeks. If you see a bad skin reaction, that means they have a yeast infection. So you should go ahead and give them diflucan or whatever else to help cover the yeast, but do not interrupt, right? And these are just some ideas on what can help. A lot of, Domboro is very expensive. We use baking soda and water, and that helps with the cis-spats. And then other things is, to help with the diarrhea and pain medicines. Yeast, this is just an example of yeast, and this is a bacterial infection. So just things to look at when you are seeing these patients and make sure that you treat the problems. The big one, this HIPAA scrub really does work, and it's a great idea to use. Okay, poll question. We ready? A patient with vulvar cancer who's felt to be unresectable due to the involvement of the right labia majora and no vaginal involvement and node negative. The patient is being treated with definitive RT due to health issues. How much of the vagina should you treat? All right. So you guys are right. 2 cm. So you guys did a great job. 84%. Great. Thank you. Thought I had some slides. Okay, next question. This one's a very easy one, right? For vulvar cancer in this female patient, which is the correct way to contour the inguinal node CTV? And again, none of these are perfect, you guys, so pick the one that you think is the best. None of them are perfect. And I promise the next couple of ones I did do better. That blue doesn't hold. The red is the R positive nodes on this patient. So the answer is A, and 71% said A. So let's look at this and see why, right? A, of course, is really nice, right? So you're going to the muscles, right behind the vessels, and then you go around. Again, we're not treating the mons, right? This is probably a little bit tight because there could be some nodes here that you're missing, right? This one, of course, is treating that entire skin bridge, and this one goes into that muscle. So that's why those are wrong. Good job. All right. Okay, next poll question. For vulvar cancer in this female patient, which is the correct way to contour the vulva CTV on the slice? The patient is post-op and the wires are placed on the scar.
And Dr. Jhingran, I think I actually have a picture from Dr. Prajogi about what his question was referring to. So we can also talk about that whenever you'd like. And it might be related to this question.
You know, and I think the problem is I also I had another couple of slides and I thought I put it in here and I was doing 2 different slides. So that unfortunately didn't get on here. So it may have been on the other slide. All right.
All right. And then I'll give it another 10 seconds and then we'll close it. All right. I'll go ahead and end it.
Okay. And the answer. And so 51% said D, and that's the correct answer. 23. Okay. So let's talk about this, right? Okay. Sorry, I'm going to end this. Okay, so let's look at the slides, right? So this one, definitely too generous, so it's going in treating the anus when this is post-op. And the other thing is it is treating a lot of the mons, right? This one probably is a little bit too tight because you are missing some of the vulva, right? And some of the vagina. Again, this one too generous because you are treating the entire mons. So here's this one, right? So this is really, here's the clitoris, right? So this is what we would do. Again, we're sparing the mons here. But as we go lower down, then you're going to bring, as the vulva comes in, and that's why the wires do help. If you put the wires on where the vulva is, you know where the vulva starts, right? This is definitely the mons. And we'll come to that question. Let's just finish all of these and then we'll come to that question. So the next question, here's the next vulva question. Okay, so this is lower down on the same patient, right? So what is the CTV? What's the correct CTV on this? And this is lower down. So now we're at the level of the true vulva. Where above we were actually at the level of the mons, and now we're at the level of the true vulva.
Okay, I'll give it another 10 seconds. All right, I'll go ahead.
56% did B, and the answer is B. You guys are really good. You don't need me. Okay, and I maybe I made it too easy. I don't know. Right, so this is way too right. Right, so you're totally missing the vulva there. This one does include the vulva, right? And the wires, so you can see. So you want margin around that, right? This one, it's a little bit too tight and not including all the vulva. And this one goes way down to the anus. Right, so great question. Great job, you guys. As I said, the reference, and I think that's it.